Hi everyone, thank you for joining us this evening. Today's tutorial is on endocrine infertility in females given by Nihara. Just a couple of rules before we start. If you're watching on the Zoom, if you have any questions, just pop them into the chat or the Q&A. If you're watching on the Facebook Live, just comment your questions and we'll make sure they're passed on. And yeah, that's all from me, and I'll hand over to Nihara to begin. Thank you.
Thank you. So my name is Nihara, and today's talk is going to be on endocrine infertility in females. So just a quick disclaimer on the tutorial. All of this is not representative of becoming a doctor, and they are the views and opinions of me. The content is made available for information and educational purposes, but it's not intended to be a substitute for any professional medical advice, diagnosis, or treatment. So yeah, like if anything in the slides discusses like diagnosing certain conditions, don't take that as the final advice. Always seek professional medical advice if any of this concerns you. And also at the end of the day, I am just a medical student, so there probably will be some things that I don't know the answer to. And if that is the case, first of all, I encourage you guys to tell me the answer if you guys know it yourself, or otherwise you can always drop me an email and I will get back to you after I've looked into it. So our learning objectives. First, we're gonna start by looking at the hypothalamo-pituitary gonadal axis in females and understand how hormones play a role in fertility. And then we're going to look at some of the conditions which can lead to infertility, specifically amenorrhea, polycystic ovarian syndrome or PCOS, and hyperprolactinemia. And we're just going to be looking at the causes, risk factors, management of these conditions. There is quite a lot of overlap between the conditions, so it is very easy to get mixed up between them. But once you understand how everything relates back to the axis, it does become a lot clearer, and we'll be referring back to the axis a lot throughout the tutorial. So to begin with, we need to understand what fertility actually means. So fertility is the ability to conceive or induce conception, whereas infertility is the inability to conceive after 1 year of regular unprotected sex. And you may hear this being referred to as subfertility sometimes. Some doctors prefer using the term subfertility. And it is fairly common, so it affects around 1 in 7 couples. And there are 2 main types of infertility. First, you have primary infertility. And this is when the couple have not been able to have any children at all. And you will also have secondary infertility. And this refers to couples who have already conceived previously, but are finding it difficult to conceive another child. And one thing that's important to remember, although this lecture is focused on female infertility, the cause of infertility can be a result of male or female or a combination of both. So now we're going to have a look at some of the risk factors. Can you guys put in the chat what you think some of the risk factors might be? If you have any ideas. So I'll give you a hint. One risk factor is age. And generally speaking, fertility does tend to decline with age and is quite a prominent risk factor in terms of fertility. Do you have any other ideas what might be a risk factor of infertility? Oh. BMI, yep, fantastic. So weight is definitely an indicator of infertility. PCOS, fantastic. Obesity, smoking, excessive alcohol use, yep, brilliant, well done. So if we go through each one of those, first we have weight. So this refers to both being overweight and underweight. So both conditions can reduce fertility, and this because it affects the ovulation. We'll talk a bit more about weight and the role of leptin in reproduction later on in this tutorial. Also, you have STIs is a risk factor, and there are several STIs that affect fertility. Some of the common ones are chlamydia and gonorrhea. And the way this works is the infection can spread to the uterus or the fallopian tubes, And when this happens, it causes pelvic inflammatory disease. And this basically means you have a lot of inflammation and a lot of scarring, and this can lead to blockage in the reproductive organs, such as the fallopian tubes. Also, like someone mentioned earlier, we have alcohol. And the precise mechanism isn't fully understood, but studies have shown it to have an effect on ovulation, and it has links to amenorrhea, which we will be talking about soon. Also, we have smoking, and this includes passive smoking as well. So the risk for fertility problems increases with the number of cigarettes smoked daily. And this is because smoking damages the genetic material in eggs and sperm, which means in men, it can affect the semen quality. And the problem with smoking is that even fertility treatments such as IVF can't always fully compensate the effects that smoking has on fertility. So for example, female smokers often need more ovary stimulating medication during IVF and will still have fewer eggs at retrieval period. And finally, we have stress. So not only can stress affect your relationship with your partner and potentially cause a loss of sex drive, in severe cases, stress can also affect ovulation and sperm production. But there is a lot of debate as to which way around this is. So because infertility is a very stressful period in itself, it could be that it's the infertility that's causing the stress. But if you think about it in an evolutionary sense, it does make perfect sense for the axes to switch off, because if your body is going under emotional stress or physical stress, it's not a great time to have a child. Next, we're going to be looking at the classifications. So this will refer to the causes of infertility. First, we have ovulatory dysfunction, and this typically means menstrual disturbances. And generally, these are split between problems with the brain and problems with the gonad. And we'll explain these in a bit more detail as we go along. This will present generally as amenorrhea, PCOS, premature menopause, and even some hypothalamo-pituitary conditions, and accounts for up to 40% of all diagnoses for women with infertility. Next, you have anatomical infertility. So this can be things like obstruction of the fallopian tubes. It could also be uterine abnormalities that are either congenital or acquired, such as Asherman syndrome, which can also lead to infertility. And also we've got endometriosis. So the endometrium is the lining of the uterus, and endometriosis is when this lining starts to grow elsewhere and outside of the uterus. For example, places such as the fallopian tube and ovaries. And if it does grow somewhere like the fallopian tubes, this can as a result cause an anatomical obstruction and lead to anatomical infertility as well. Also, the problem with endometriosis is that it can lead to infertility by producing cytokines, as these are toxic to sperm and embryos. Finally, we have this thing called idiopathic. So infertility can be caused by many different things, but the reason isn't always clear. And for a quarter of couples, the cause can't actually be identified. So we use this word idiopathic to describe unexplained infertility. It's basically just a fancy word for saying, I don't really know. Today's tutorial, however, we're going to be focusing on ovulatory dysfunction. So to our first learning objective, we're going to be talking about the hypothalamo-pituitary gonadal axis in females. And I'll be referring to this as the HPG axis. However, it's probably more accurate to say hypothalamo-pituitary ovarian axis, because that's more specific to females. So this is what it looks like. You have the hypothalamus at the top, which is connected to the anterior pituitary. This releases hormones onto the ovaries. So if I talk about this in a bit more detail, the hypothalamus releases GnRH, gonadotrophin releasing hormone, which then in turn acts on the anterior pituitary gland to release gonadotrophs such as LH and FSH, which are respectively luteinizing hormone and follicle stimulating hormone. This, as a result, acts on the ovaries in a number of ways to produce estrogen. This is quite a simplified diagram of the axis, but this is all you really need to know about the axis to understand infertility. You don't need to go into it in that much detail. So again, I've got the axis here on the left, and on the right we have a graph, and stages of the menstrual cycle and how it all relates to one another. So on the left with the flow chart for the axis, we've replaced ovaries with the specific cells it acts on, so the granulosa cells and the theca cells. So what happens is the LH and FSH will stimulate follicle growth, and this will produce estrogen and will help stimulate the follicles, and the theca cells will produce androgens, which are then converted into estrogen as well. Estrogen has a very interesting effect because it exerts negative control through like a negative feedback loop with the hypothalamus and the anterior pituitary. And this is so that you keep the estrogen levels in check and it doesn't get too high. However, during the follicular phase, and you can see that with the graph on the right, you can see that as estrogen levels rise, there is a sudden peak in the red line, which is the line for LH, and this is the LH surge. This is because estrogen switches from negative to positive feedback, and it makes LH more sensitive to GnRH, and thus making an LH surge. The LH surge is really important because this is what triggers ovulation, or in other words, the release of an egg. If either the follicle growth does not occur or if the ovulation does not occur, then we get problems with fertility. In other words, ovulatory dysfunction. So first we're going to talk about primary gonadal failure. Again, here we have the flow chart on the right. Primary gonadal failure can also be called hypergonadotrophic hypogonadism. So hypogonadism basically means reduced function of the gonads, in other words, gonadal failure. The reason why it's called hypergonadotrophic is because of the levels of gonadotrophs being produced. So when you have gonadal failure, estrogen is not being produced like it normally should, and therefore you don't have the negative feedback loop as you normally would to the brain. The brain thinks that you're not getting enough estrogen, which is true in this case. So what then happens is it pumps up a lot more gonadotrophic releasing hormone, and as a result, there is increased levels of FSH and LH. Unfortunately, however, this does not have an effect on the estrogen levels because we have a problem with the gonads or with the ovaries. And when you look at blood samples, what you're left with is high FSH levels, high LH levels, and low estrogen. And because we have low estrogen, we cannot ovulate. Similarly, we have secondary gonadal failure. So once again, it's hypogonadism because it's gonadal failure. We have a reduced functionality of the gonads. But this time it's hypogonadotrophic, which means that you have reduced levels of gonadotrophs. So here, the problem lies with the brain and the pituitary. So the hypothalamus and the pituitary aren't producing enough gonadotrophins and gonadotrophin releasing hormone. So we have low levels of all of these hormones. And because we have low levels of each of these hormones, we have low levels of estrogen. So essentially, when you get your bloods, you have low levels for all of these hormones. Okay, we'll do a quick knowledge check. So let me open up the poll for this question. Give me a second. Launch poll. Okay, so the question is, which of the following best describes the role of estrogen? I'll give you some time to answer this. I think there are a few more people who haven't voted yet, so I'll just give a few more seconds. And of course, have a guess, even if you're not sure. We're going to go through the answers in just a moment. Okay, I'm going to end the poll in 3, 2, 1, and end. So it looks like majority of you went for B, which is the correct answer, it inhibits the secretion of GnRH. So if we go through each answer option, A stimulates the production of androgens. That's not quite correct because that's what LH does with the theca cells, as you might have remembered from the diagram. C initiates follicular growth in ovaries. Whilst it is correct in a sense, it does this indirectly. So it's more correct to say that FSH stimulates the follicle growth. D causes ovulation. Again, it does indirectly cause ovulation, but it's more correct to say that LH is what caused the ovulation. And finally, E causes the formation of corpus luteum. I didn't cover that in this slide, but it is LH that forms the corpus luteum. So well done to those of you who put B. Okay, next we've got our next learning objective, amenorrhea. I'm just going to quickly check the chat to see if we have any questions that I need answering. Okay, so we have one question. Can we repeat why we get an LH peak? The reason why we get the LH peak is because once your estrogen levels rise to a certain point, it switches from negative feedback to positive feedback. And when this happens, the LH becomes more sensitive to gonadotrophin releasing hormone. So gonadotrophin releasing hormone increases and LH also increases at an exponential rate. And that's why you get that surge. Okay, we'll move on to amenorrhea for now. So amenorrhea, we're going to be talking about the definition of amenorrhea and understand some common causes, investigations, and treatment. So first, we're going to have a look at a number of different menstrual disorders. There are many different names for various menstrual disorders, and it's very easy to get mixed up between them. So I'm just going to use this slide to cover each one and what they mean. So first of all, we have amenorrhea, and simply put, this is an absence of menstruation. And there are a number of different causes for this, which we will go through in detail later on. We have dysmenorrhea, and these are painful cramps during menstruation. The pain usually occurs in the lower abdomen, but it can radiate to the lower back and the thighs. And this is because of prostaglandins. So these cause contractions, and the contractions is what causes the pain. And whilst it can be physiological, there are some pathophysiological reasons for it as well, such as endometriosis and fibroids in the uterus. We also have menorrhagia. This is the medical term for significantly heavier periods. So during a normal menstrual cycle, the average woman loses about an ounce of blood, so that's about 30 mils. But with menorrhagia, the menstrual flow lasts a lot longer and it's a lot heavier. And again, it can be caused by a number of factors, such as hormone imbalances, fibroids, polyps, contraceptives, and also certain medications, such as anticoagulants and anti-inflammatories. Next, we've got metrorrhagia. So this is bleeding at irregular intervals, particularly between expected menstrual periods. Sometimes it can be called breakthrough bleeding or spotting as well, and this is when bleeding occurs between periods or it's unrelated to a period. And spotting and light bleeding in between periods is actually quite common in girls that have just started menstruation, and sometimes during ovulation in young adult women as well. Next, we have oligomenorrhea. So this is infrequent menstrual periods. In other words, the cycles are longer than useful. Can you guys tell me in the chat, how long is a typical menstrual cycle? Does anyone know? Yeah, 28 days. So most textbooks will say 28 days, but actually it's pretty rare to find a woman who has exactly 28-day cycles. So in practice, cycles between 21 to 35 days are completely normal cycle lengths. Oligomenorrhea means the cycles are much longer than that, and it could be maybe every few months, for example. Next, we also have hypomenorrhea, and this essentially just means light periods. The flow is a lot lighter than usual, or than it's meant to be. So, amenorrhea, this can be split up into primary and secondary amenorrhea. Primary amenorrhea is the failure to develop spontaneous menstruation by the age of 16 years old. so it means you've never had a period. Secondary amenorrhea means the absence of menstruation for 3 months in a woman who has already had cycles previously. So you used to have periods, but for some reason you've stopped having periods for a number of months. And because in secondary amenorrhea, the axis was working at one point, because you did used to have periods, the cause of secondary amenorrhea is probably not congenital. So because, like I said, the axis was working, so it can't be a defect that happened since birth. Okay, this is another poll that I want to open. Let me just get it up. Number 2. Okay, so what do you guys think is the most common cause of amenorrhea? I've opened the poll. I haven't given away the answer yet. I want to know what you guys think. We have chemotherapy, Turner syndrome, post-pill amenorrhea, pregnancy, and gonadal tumor. I'll give it a few more seconds just to let everyone answer. Okay, I'm going to end the poll in 3, 2, 1, and end. So most people have gone for pregnancy as the most common cause of amenorrhea, and that is indeed correct. So again, most people don't realize that pregnancy also is a valid cause of amenorrhea, although it's specifically for secondary amenorrhea, because if you had primary amenorrhea, chances are you probably wouldn't get pregnant because your axis wasn't working in the first place. So let's talk about the causes in more detail. First and foremost, you have pregnancy and lactation, and these are physiological causes of amenorrhea, so it's completely normal and the body is functioning as it should. This is because during pregnancy and lactation, you have very high estrogen levels, and as we learned before, estrogen has a negative feedback on the axis. And also, it does make sense that if you are already pregnant and you've just given birth, you don't really want to conceive another child, especially because it has a huge toll on the body and you just wouldn't be able to handle the burden. You also have weight loss. So weight loss and illness both can switch off the axis. And for weight loss, it's specifically due to leptin deficiency. Leptin is a hormone that is released by white adipose tissue in the body, so fat, and it basically has a permissive role in the initiation of puberty and maintain the hypothalamic-pituitary gonadal axis. So what this means is leptin being present allows the axis to continue as usual. Therefore, having reduced fat levels means reduced leptin and therefore switches off the axis. And once again, from an evolutionary perspective, this makes sense. If your body thinks that there is a lack of food supply available and lack of resources, it's probably not the best time to bring a child into the picture. Again, especially because pregnancy has such a huge toll on the body and you need to be able to be physically capable enough to handle the pressure. Next, you also have ovarian failure. So one example is premature ovarian insufficiency, in other words, premature menopause. This is when you run out of eggs, and if you don't have any eggs, you won't be able to ovulate. Oophorectomy and ovariectomy. Essentially, this is when the ovaries are removed. So once again, if you don't have ovaries, you can't release the egg and conceive a child. Chemotherapy, so some chemotherapy drugs can also damage the ovaries, and this increases the risk of infertility as well as potential early menopause. And finally, we have ovarian dysgenesis, an example being Turner syndrome. So let's have a look at Turner syndrome in more detail. Here is an example of someone with Turner's and what they would typically look like. So it's a condition that only affects females, and it's when one X chromosome is either completely or partially missing, hence why the chromosome number is 45 as opposed to 46. And it occurs 1 in every 5,000 live female births, so it is extremely rare. And the presentation is highly variable, and it differs dramatically from one person to another. but some common presentations are short stature, so they tend to be quite short, cubitus valgus, and this is when the forearm is angled slightly away from the body to a greater degree than normal when it's fully extended. And you might have heard of this as a carrying angle. So cubitus valgus essentially means a larger than usual carrying angle. You will also have a webbed neck and gonadal dysgenesis. So the ovaries have not developed properly, and that leads to problems such as amenorrhea and infertility. And you will also have some other defining features. So for example, a low posterior hairline, and also a broad, almost shield-shaped chest, and also pigmentations around the body as well. More causes include gonadotrophin failure. So whilst before ovarian failure referred to primary gonadal failure, gonadotrophin failure is secondary. So this is when the problem is with the brain and the hypothalamus and pituitary. So first and foremost, hypothalamo-pituitary disease is a potential factor. And essentially this is just secondary gonadal failure because the problem lies with hypothalamus and pituitary. You can also have Kalman syndrome. Now this affects either men or women, and this is a failure of the gonadotrophin releasing secretion, GnRH secretion. And an interesting fact about Kalman syndrome is it's often accompanied by a lack of smell, so anosmia. And whilst it doesn't seem at first like smell and GnRH secretion would go together, this is because embryologically, the olfactory nerves and the GnRH nerves will migrate together during embryogenesis. So if you get a problem with this migration, then you end up affecting both the olfactory nerves and the GnRH secretion. You can also get post-pill amenorrhea. So essentially what the pill does, it will downregulate the hypothalamus and the pituitary. And if you use the pill for a long time, then essentially your hypothalamus and pituitary tends to go to sleep, and it takes a while for it to kickstart again. And this is why when people are on the pill, they should be advised to stop the pill every 4 months and let their period return before continuing with it to avoid post-pill amenorrhea. Otherwise, it can take up to 12 months after cessation for your periods to come back again. Hyperprolactinemia is another cause. The lactation, whilst it was physiological in the previous slide, can also be pathophysiological and cause hyperprolactinemia. And we'll talk about this in more detail later on. And finally, if you have androgen excess, such as a gonadal tumor, this can also cause amenorrhea. And this is quite easy to diagnose because testosterone will be in excess. However, it is quite a rare cause, so you don't often see it in clinical practice. So investigations, first and foremost, you want to check whether or not they are pregnant. And pregnancy tests are fairly cheap and quite quick and easy to do. So this should be one of the first things you consider. Also, you want to have a look at bloods. So the issue with LH and FSH is because in a woman's menstrual cycle, it will vary greatly from one woman to another. So it's very difficult to compare the numbers between LH and FSH. However, if LH and FSH and estrogen are very low, then that would indicate secondary gonadal failure. However, generally speaking, they're not the best indicators. It doesn't tell you that much. We look at androgens to see if things like PCOS is playing a role, and also prolactin to see if hyperprolactinemia is an issue. You also have day 21 progesterone. So in the second half of the menstrual cycle, the progesterone will rise over a prolonged period of time, and there should be quite a nice bump on the graph. And this will basically show if you are ovulating. However, the cycle does differ greatly between women to women. So we often say test the progesterone at day 18, 21, and 24, just to account for the differences. And also, even though you might have your period every single cycle, you won't always ovulate every single cycle. So it's a good confirmation to the women whether they are ovulating or not. And it helps with pregnancy planning. We also have thyroid function tests. This is because hyper and hypothyroidism can both cause problems with periods, and also ultrasound scans. So again, this will help with PCOS diagnoses. And as before, we can look at chromosomal analysis. So the posh word for this is karyotyping, to see if a genetic cause such as Turner's is the problem. Finally, you can also look for an MRI in the brain. So if there is a tumor that is causing the problem and is pressing against the pituitary and causing problems that way, you can help diagnose it with an MRI of the brain. However, you should only do this if you are fairly certain that this could be a cause. So treatments, to treat amenorrhea, we need to treat the cause of amenorrhea. So when the causes are pregnancy, lactation, pregnancy and lactation, it's physiological. So all you have to do is wait for that to pass. And if it's weight loss, you need to consider lifestyle advice. So dietary advice, exercise, and basically just trying to maintain your weight. When the problem is ovarian failure, you can give hormone replacement therapy to help bring the estrogen levels back to normal. But because the problem is with the ovaries, it means you can't ovulate no matter how many or no matter how much estrogen you actually have. So even if you give HRT, the chances are the fertility might not be treated. Whereas if it's a gonadotrophin failure, you can give HRT for estrogen replacement, and also you can give gonadotrophins as part of IVF treatment. Because as long as the gonadotrophins are there, this will help kickstart the estrogen axis and will help you ovulate as usual. So we've got another knowledge check. Which of the following is not a feature of Turner syndrome? So again, I'm just going to reopen the poll there, and I'll give you guys some time to vote. This is probably a pretty easy one because I did go into a lot of detail, and a lot of you do seem to be answering it pretty quickly. That's great. I'll give you a few more seconds for the people who haven't answered yet. Okay, and 3, 2, 1, end. Most of you got it correct. The answer was anosmia, because anosmia is a feature of Kalman's, whereas all the others are features of Turner's. Well done. We have another one, so have a go at this. Let me just relaunch this one. Give me a second. Okay, number 4, launch. Have a go at this question. I'll give some more time for the people who haven't answered yet. Okay, I'm gonna end the poll in 3, 2, 1, and end. Okay, so it looks like most of you did get it. If we just quickly go over the case to begin with. So we have a 35-year-old woman, Alice, and her 36-year-old partner, Jacob. They've come to the fertility clinic after trying for a baby for 2 years. The referral letter notes that her period only comes once every few months. Alice has not conceived before, but Jacob has a child from his previous marriage. So in terms of the cause, chances are the cause is probably lying with Alice, because Jacob has already conceived a child. It's probably a problem with the female in this case. And the question was, which of the following does Alice have? So which of the following menstrual disorders? The answer was C. So well done to those of you who got C correct. If we go through each one by one, amenorrhea means a lack of periods. That's not true because she does get them. Menorrhagia means heavy periods, and hypermenorrhea means light periods. It doesn't actually mention the flow, so we can't consider those as options. Metrorrhagia is usually the one that people get confused with. So this is when the periods are irregular, but in this case, it does say it comes every few months. So whilst they are far apart, they do seem to be regular. So the answer is oligomenorrhea. And well done for those of you who got it correct. Okay, so next we're going to have a look at PCOS. I'm just going to quickly check the chat in case there's any questions. Looks okay for now. Okay, so that's fine. I'll start PCOS. So let's start by talking about what it actually means. So polycystic ovarian syndrome. This is a common lifelong condition, and it's actually more common in Indigenous and Southeast Asian women. And basically, it results in a hormonal imbalance, which results in the associated signs and symptoms, such as infertility, androgenism, and so on. So if we take it bit by bit, ovarian, quite self-explanatory, it means it happens at the ovaries. You don't need to know the anatomy in so much detail, you just need to be able to visualize it. So the ovaries are paired structures on either side of the uterus, and they're situated quite close to the lateral pelvic wall. And for any keen anatomists, they are also the only intra-abdominal structure that is not covered by the peritoneum. Cystic, so a cyst is essentially a sac or a pocket in your body that is filled with fluid or a semi-solid material or air. And in PCOS, these are basically overgrown follicles. So follicles that have just been growing and growing and growing, and they're not being released properly because there's not enough estrogen, there's hormonal imbalance, and so on. So if you have a look, here is an example of ovaries. They are the large sort of spherical structures in the bottom left corner, and it tends to take a string of pearls-like appearance. It's poly because you need to have multiple cysts, specifically more than 12 for it to count as PCOS. And also it's a syndrome. So a syndrome basically means there are multiple anomalies that are involved, and they're thought to be pathogenetically related, but they're not necessarily representing a linear sequence. Another example of a syndrome is Down syndrome. So again, we'll have a look at risk factors. First, we've got family history. So it does seem to be a hereditary link to PCOS, and you're more likely to have it if your mother or sister has it. Again, obesity does play a role. So it's a common finding in PCOS, and it can make PCOS symptoms worse. However, PCOS affects women of all shapes and sizes. It doesn't necessarily mean it's only overweight women that are affected. Low birth weight is also a risk factor. Also, fetal androgen exposure. So an androgen is basically a hormone that regulates development and maintenance of male characteristics, for example, testosterone. And an excess of this will lead to some presentations of PCOS, for example, excess hair growth, etc. And finally, we have premature adrenarche. So this is seen in about 50% of PCOS cases. So early adrenarche basically means the awakening of the adrenal gland. So it's when the sex hormones start to be produced at a more rapid rate and causes changes such as development of pubic hair, oily skin, oily hair, and also body odor. But on a side note, remember that premature adrenarche is not the same as puberty. Puberty is when the body becomes capable of sexual reproduction. So in other words, development of the secondary sex characteristics such as testes and ovaries. Adrenarche is more like the precursor to puberty. Now we're going to have a look at some signs and symptoms. So I touched upon it briefly before. Does anyone know examples of signs and symptoms in PCOS? So what might you find? Hirsutism, yep, fantastic. That's the one that most people know. Yep, male style balding as well, fantastic. Acne, brilliant. Yep, oligomenoria as well, fantastic. So first and foremost, menstrual disturbance is a category of the signs and symptoms. Now, there is a long list of potential signs and symptoms that are associated with PCOS, but actually, instead of memorizing that list, it's a lot easier to think of it in terms of which compartment it falls under. So for menstrual disturbances, you'll get things like oligomenorrhea, secondary amenorrhea, cystic ovaries, and also infertility is a complication of the previous causes. Next, you have hyperandrogenism. So within hyperandrogenism, you have hirsutism and acne. Hirsutism is excessive hair growth of dark or coarse hair in a male-like pattern, so on the face, chest, and back, but it can also present as male pattern balding, like someone mentioned earlier. And again, you have acne, and this is because androgens tend to correlate with higher sebum production, which leads to oily skin and acne. You also have insulin resistance. So people with PCOS have a reduced insulin sensitivity, and that means you need higher than usual levels of insulin to maintain normal blood glucose levels. But high levels of insulin will lead to increased production of androgens, and this will then feed back into the hyperandrogenism section. But also you get complications such as hypertension, which can lead to increased risk of cardiovascular diseases, and also dyslipidemia as a result of the high insulin. And dyslipidemia is basically inappropriate sort of fat production, for example, like around the belly and so on. Or probably inappropriate fat distribution is probably a better way of saying it. And finally, again, as a result of the insulin resistance, you can get obesity. So within obesity, you can get complications such as hyperglycemia. And as discussed earlier, increased fat will also increase the levels of estrogen production because of leptin. And having abnormally high estrogen levels is also quite dangerous because it increases the risk of many other conditions, such as thyroid dysfunction, breast cancer, and even strokes. But the typical clinical presentation of a woman would be a young woman who is experiencing irregular periods with weight gain and or hirsutism. And this is what they will usually look like in a clinic. So some differential diagnoses to consider. Just because they have all the symptoms that align with PCOS doesn't mean that the answer is definitely PCOS. We have to consider other possible causes for the same set of symptoms. So again, we will compartmentalize it into the different symptoms and what it can be caused by, rather than just trying to memorize a list. So for ovarian cysts, other things that can cause the ovarian cyst are endometriosis and functional cysts. So endometriosis, we spoke about this before at the beginning. Well, with the growth of the endometrium, sometimes it can cause blood-filled cysts, and these usually enlarge just before and during menstruation and slightly shrink afterwards. And the ovary is the most common site of pelvic endometriosis. And for functional cysts, this is essentially a physiological reason for ovarian cysts. It's not a problem, it's just the normal function. So a functional cyst, for example, is, it could be a sac that forms on the surface of the woman's ovary, again, during or after ovulation, and it holds the maturing egg. And usually the sac will go away after the egg is released. And if the egg is not released, the sac just closes up and the egg releases, and the sac can swell up with fluid sometimes. And that's why you get the functional cyst. You also have menstrual disturbances that can cause the amenorrhea and so on. So for example, hyperprolactinemia is a potential cause. Again, we'll talk about that in the last learning objective. For hyperandrogenism, it could be due to congenital adrenal hyperplasia. This basically means enlarged adrenal glands, and it's an inherited condition because of an enzyme deficiency, and it's the most common adrenal disorder in children. Basically, this results in excess production of androgens, so the male hormones, which will result in the hyperandrogenic effects, such as hirsutism and acne and so on. And finally, for obesity and insulin resistance, potential differentials could be hypothyroidism, which essentially means underactive thyroids. And this presents as decreased thermogenesis, decreased metabolic rate, and obesity is quite a common presentation. You also have Cushing's syndrome. So with Cushing's, the symptoms vary quite widely between individuals, and it depends on the cause really, but weight gain is a key symptom amongst most patients. And you might have heard the terms moon face and lemon on sticks when describing patients with Cushing's syndrome. So investigations, first of all, you want to do an HCG test to exclude a potential pregnancy. You also want to do a full blood count to assess that all the hormone levels and so on and everything is correct. You also want to do a blood glucose test to ensure it's not, or to think about the insulin deficiency or the high levels of insulin rather. And also thyroid function test as well to look for hypothyroidism. And also with the hormones, LH and FSH, like I mentioned before, aren't the best indicators, but it can sometimes give you an idea of what it could be, and also progesterone. You can also look at prolactin as well to look for prolactinemia. And finally, on the ultrasound, either vaginal or abdominal, if you can see cysts in the ultrasound, then that's a pretty good indicator of PCOS as well. And here is what it would look like on the ultrasound. So the large black circles would be the cysts. So to diagnose a person with PCOS, they need to have two of the following: amenorrhea, oligomenorrhea, hyperandrogenism, either clinical or biochemical, and polycystic ovaries on the ultrasound. So with clinical hyperandrogenism, we've mentioned before hirsutism, can either be excess hair growth or male pattern balding, or it might just be increased levels of testosterone. And polycystic ovaries in the ultrasound, whilst it is a pretty good indicator, that on its own is not enough to diagnose PCOS. You do need two of these three categories. So for management, again, we're going to take it based on each symptom and each issue with PCOS. So the first one is amenorrhea. For this, you can use low-dose combined oral contraceptive pill, and this will help just realign the estrogen levels, and it will also help with the hyperandrogenism as well. And you can also use progesterone every 12 days for maybe for 12 days every 1 to 3 months, and this would help to induce a withdrawal bleed. But this is mainly for women who are not planning to become pregnant. For women who do want to become pregnant, we need to treat the infertility itself, and can use clomiphene citrate to induce ovulation, and we'll talk about this in more detail in the next slide. But for the women who don't respond that well to clomiphene, we can use gonadotrophin therapy as part of IVF treatment, and this does sometimes help. For the hyperandrogenism and hirsutism, we can use anti-androgens, so like the name suggests, works against the androgens. There are many cosmetic techniques as well, which can help with the hair growth, etc. And spironolactone has some anti-androgenic properties as well. And for BC and insulin resistance, we want to make sure they have good lifestyle advice, so proper dietary and exercise advice to get that under control. And if not, we can think about metformin as well to help with the insulin sensitivity. So clomiphene, this is used to treat subfertility, and it works by having an anti-estrogenic effect in the HPG axis. So if we go back to the axis, it acts as an estrogen receptor blocker. So the estrogen has a negative feedback in the hypothalamus-pituitary. But when you have clomiphene and it blocks the estrogen receptor, estrogen cannot bind to these receptors, and it cannot induce a negative feedback. So as far as the body is concerned, there's not enough estrogen. And as a result, they start increasing levels of GnRH, FSH, and LH. And therefore, they will increase the levels of estrogen. And by doing this, you can induce ovulation. So it's basically a way to kickstart the HPG axis. And it can be used in short periods as well. But yeah, basically it works to kickstart the axis and to induce ovulation, and that's how it helps with treating fertility. So we've got another question, if I open up on the poll. This one, launch poll. have a go at this question. I'll give a few more seconds for those who haven't answered yet. Okay, and have a guessing if you're not sure. I'm going to end the poll in 3, 2, 1, end. Okay, so majority of you went for combined contraceptive pill, which is correct. Well done. So again, if we go through these options, the case is a 20-year-old student complaining of irregular periods with excess facial hair and spots. She's noticed her weight has increased by 5 kilograms. She's not worried about the periods, but she is worried about the changes to her appearance. We want to know what the first line treatment is going to be. So because she is worried about the changes to her appearance, it is tempting to go for C, anti-androgens, as the answer. But actually, the first line medical treatment would be the oral contraceptive pill. This is because it will help regulate her bleeds. Even if she isn't like that concerned, doesn't really mind it that much, it's really important to ensure that her estrogen levels are being regulated properly. And also, as mentioned before, the contraceptive pill also has effects on the hyperandrogenism. So it will help reduce the facial hair growth by elevating the sex hormone binding globulin. And what this does, it mops up all the free testosterone and reduces serum testosterone in the blood. And that's how it acts as an anti-androgen. However, despite this, the most important treatment in this case would be to reduce her weight, because often once the weight has come back to normal, it will promote spontaneous ovulation. Whilst metformin is here, it would be a much better answer if this was lifestyle and dietary advice, but metformin specifically more to do with insulin sensitivity. So that's why that wouldn't be the best answer. And likewise with clomiphene, that's only needed if she wants to be pregnant and she hasn't expressed any wishes of wanting to conceive. It is really important, however, no matter the age and the background, to assess what their thoughts are on conception and what their future plans are, because depending on that, we will adjust the treatment to give them the best possible medical treatment, essentially. And lastly, an ultrasound scan, it's a diagnostic tool, not a treatment, so it wouldn't be a first-line treatment. And we'll have a look at hyperprolactinemia next. This is the final this is the final learning objective. I'm just going to have a quick look at the chat, see if there's any questions. Okay, so we have a question. Could you repeat why the oral contraceptive pill is used for amenorrhea? Yep, of course. So let me just get that slide up. So basically, with the pill, it helps treat it because it will bring the cycle back to normal, and it will help to realign and reset the estrogen levels, if that makes sense. And that's why that's really important. Whilst it does help to prevent ovulation, it should help to induce the bleed as usual, because it will be a combination of estrogen and progesterone often. And this is why it will help with inducing a withdrawal bleed. Hopefully that makes sense. And if there's no other questions, I will continue with hyperprolactinemia. Yep, okay, perfect. So to begin with, what is prolactin? So prolactin is a hormone produced in the anterior pituitary gland, and it's mainly known for its role in lactation. It also has other wide-ranging functions in the body, but the main role is lactation. And the interesting thing about prolactin is that it works under negative control by the hormone dopamine. So if we get our axis back up, this time we have the hypothalamus and anterior pituitary in terms of dopamine and prolactin. So the hypothalamus will secrete dopamine to act on the anterior pituitary, and this will act on the lactotroph cells in the anterior pituitary to keep prolactin suppressed. So dopamine secretion keeps prolactin suppressed. However, what happens is when there is high levels of estrogen, the dopamine is inhibited, and therefore the prolactin axis can therefore be switched on. Therefore, we have an increase of prolactin, and this will have effects on lactation and other parts as well, specifically the axis concerning GnRH and FSH-LH. Prolactin has negative feedback control on GnRH, so that means GnRH will decrease and FSH and LH will also decrease as well. And if this is decreased and switched off, ovulation will not occur. So when you are lactating, you most likely won't be able to ovulate. Why is there a problem? Well, it makes sense in terms of physiological reasons. So if you're pregnant and if you're lactating, you don't want to be conceiving another child. So it makes sense for you to lactate, and it makes sense for you to be infertile. However, the problem happens when prolactin levels are increased when you are not pregnant and when you are not lactating like you should do. So this will lead to unwanted lactation. So if you're not pregnant, you don't want to be lactating, simply put. And also hypogonadism. So like I mentioned, it has negative feedback control on GnRH and FSH and LH. And this means the gonads will have reduced function. You're not able to ovulate and you're not able to conceive, and therefore you get hypogonadism. This basically presents as infertility and can also present as vaginal dryness. And this is also an important factor as well, because it can lead to dyspareunia. This is when you have painful sexual intercourse, so it hurts when you're having sex. And finally, it can be because of a prolactinoma. So a prolactinoma is when there's a tumor that continuously secretes prolactin. And this is a problem because a tumor in the brain can cause headaches, and it can also cause visual field defects. And the reason for this is the pituitary gland sits right below the optic chiasm. So if there is any kind of obstruction around the pituitary gland, it can potentially compress against the optic chiasm and therefore lead to visual field defects. So some causes: first of all, having high estrogens, so pregnancy, lactation, and contraceptive pill. But also you can have dopamine antagonists as a cause, so certain medications such as antiemetics, such as metoclopramide, and antipsychotics, so phenothiazines. And these can essentially act as antagonists to dopamine. So what happens is dopamine is antagonized, it doesn't work as it normally should, so the prolactin axis is switched on. You can also get prolactinoma, which I mentioned before. So you can also get pituitary adenoma. If I show you this image here, the image is quite complicated at first, but all we need to focus on is the hypothalamus, the anterior pituitary down there, and the stalk that runs between them. So this stalk is how the dopamine gets from the hypothalamus to the anterior pituitary, and also how the GnRH gets from hypothalamus to pituitary. But if there is a tumor around this area that compresses against the stalk, then there is a blockage and the dopamine can't get to the anterior pituitary. This means the prolactin axis is not under negative control, it is in fact switched on and can lead to hyperprolactinemia. PCOS, again, is also a symptom, and also hypothyroidism. And this is because TRH, so TRH also has an effect on prolactin control. So it helps, it has a positive control on prolactin, but it doesn't have as much of an effect as dopamine, so we don't talk about it as much. And again, we have idiopathic. Sometimes the cause is just uncertain and we don't really know. So how do we go about treating it? We need to treat the cause. first of all, if it's pregnancy and lactation, then we can just wait for it to pass and it should be fine. If it's because of the pill, then quite simply you can come off the pill as long as it's okay for you to do so. But the problem is with the dopamine agonists, examples of dopamine agonists, antagonists are the antiemetics and antipsychotics. So antiemetics tend to be short-term, and hopefully you're not on it for too long and it shouldn't really cause a problem. But antipsychotics tend to be a long-term medication, so it's quite difficult to come off the medication as a way to treat the hyperprolactinemia, and it's often a cause of balancing between, you know, the two conditions and which is more important. And also with prolactinoma, you can use dopamine agonist therapy, and like the name suggests, it agonizes the dopamine, so it makes it work more, and if the dopamine is working more, that means the prolactin is being suppressed and it's switched off. So prolactin is not being produced. And there is also the option of doing pituitary surgery, so removing the tumor surgically. However, this is often rarely needed because the drugs usually work well enough and often can lead to decreasing the tumor size as well. I want to be talking about an example of this in this slide. So cabergoline is an example of a dopamine receptor agonist. And again, here is our axes to help understand how it works. Dopamine is what starts the negative feedback control in the first place. If there's not enough for whatever reason, or if it's not working properly, then the negative feedback control is not going to work as usual. So what cabergoline does, it essentially mimics dopamine, and by doing so, it helps reassert the negative control and helps suppress prolactin. And often it can do it enough so that it will reduce the tumor size as well. Generally speaking, more dopamine equals less prolactin and vice versa. And this is a long-acting drug and it's quite strong as well. So often you only need it a couple times a week for it to work. Okay, and now we've got another knowledge check. So let me reopen the poll for this question. Number 6, okay. So which of the following best describes how prolactin leads to infertility? I'll give a few more seconds for those who haven't voted yet. Okay, have a guess if you're not sure. I'm going to end the poll in 3, 2, 1, and end. So most of you have gone for inhibits GnRH secretion, which technically it is correct, but it's not the best answer. And the reason being, because it actually inhibits a GnRH pulsatility more than secretion. So it's quite mean of me because I didn't give it away when I was explaining the slides. So what happens is GnRH is released basally, like just throughout normal function. And what prolactin does, it inhibits the pulsatility. So in order for FSH and LH to occur, it's not enough for GnRH to be released in normal amounts. It needs to be released in pulses. And it's this pulsatile manner that causes FSH and LH to be secreted. So what prolactin does, it inhibits the pulsatility, and that is why it would lead to infertility. The other answer options aren't quite correct because it's actually lactotrophin stimulation which releases prolactin. And also B, it's the other way around. For D, also, yes, it does technically speaking inhibit follicular growth, but it does so indirectly, so it's not the best answer. And we have one final question before we end. Let me reopen the poll for this one. And polling and launch. I'll give a few more seconds for those who haven't got an answer down yet. Okay, have a guess even if you're not sure. I'm going to end the poll in 3, 2, 1, and end. Okay, so most of you went with option A, that's low LH, low FSH, and low estradiol, which is correct. So well done for those of you who put A. So essentially, she is lactating and her prolactin levels are very high. When prolactin is very high, this will inhibit the pulsatility. So this means you have low FSH, low LH, and therefore low estradiol. You have low levels of everything. In other words, it's a type of secondary gonadal failure. If you remember from the very first few slides, it's hypogonadotrophic hypogonadism. So when all the levels are low. And well done for those of you who got it correct. Okay, so now that we've come to the end, some takeaway messages. First of all, understand the HPG axis and how it relates to each condition. And once you do this, it becomes a lot more clearer how it all connects to one another. Be able to explain why each condition presents the way it does. So why is it that amenorrhea, PCOS, etc. have the signs and symptoms that they do, and what is it in the biochemistry that causes it? Remember that some causes may be physiological. So pregnancy, lactation are very common physiological causes of some conditions that might otherwise be pathophysiological. Understand the differentials of PCOS and the relevant investigations required to dismiss them. So it's very easy to see typical PCOS symptoms and diagnose PCOS, but you cannot diagnose it without eliminating the possible differentials. And you can use the investigations and the history taking as well to eliminate these options. And finally, really understand the patient and what they want. And this is the best way to personalize their treatment and cater to their specific needs. So whether or not a person is intended to conceive or not is a big factor on how you're going to adjust their treatment, essentially. And then here is just a list of some of the resources I use. So I used some textbooks such as Gynecology by 10 Teachers and also the unofficial guide. I used the NHS website and B&J best practice, nice guidelines. And also I found quite a nice website which has lots of biology and medicine videos and pictures. So I use that as well. Okay, and that is the end of these slides. Hope you guys enjoy the tutorial. Please fill out the feedback form if you have time. It should only take less than a minute, and I will answer any questions you guys have. Let me see what questions there are. There's some in the Q&A. Are all PCOS patients infertile? So PCOS essentially can present as infertility, but not always. It really depends on what their specific symptoms are. So if we remember the previous slide, you need to have 2 of the following in terms of a menstrual disturbance, hyperandrogenism, and polycystic ovaries. So it could be that they have hyperandrogenism, polycystic ovaries, but actually they don't have amenorrhea or oligomenorrhea, and they can ovulate properly. So it's not always the case that every PCOS patient is infertile. It really depends and differs a lot between each one. Can fibroids cause infertility? I believe they can, but I think it really depends on the type. If you like, I can probably get back to you with a better answer for that question. If you guys do have any questions that you want an actual in-depth answer to, I'll just leave my email in the chat. So just email me and I can get back to you with a proper answer. But off the top of my head, I'm not entirely sure for that question. Let me check if there's any more. I don't think there are any more. I believe that is all the questions. So yeah, okay, brilliant. Hope you guys all enjoyed the tutorial, and we will leave it there for today. Thank you.